All right, so we'll go ahead and get started with today's presentation. So once again, just a quick reminder about the AMSSM Library of Sports Ultrasound Pathology. So this is a great opportunity to take the pathology that you see in clinic, the training room, or on the sidelines and actually turn this into a publication. And so the AMSSM Sports Ultrasound Committee is still looking for both common and unusual pathology related to sports ultrasound to highlight within the library. So this is a really great way for residents, fellows, and staff to add to the growing case series of ultrasound pathology and also get a peer-reviewed reference for your CV. So more information can be found on the AMSSM webpage under the Sports Ultrasound tab, or you can also email Josh Romero. Otherwise, going to be introducing our speaker today. This is Dr. Derek Stokes. He's a current sports medicine fellow at the University of Utah in Salt Lake City. He completed his medical school at the University of Missouri Columbia, and then a PM&R residency at the University of Colorado, where he'll be returning next year actually as an assistant professor. He's already had active involvement in the AMSSM, consisting mostly of work in the education and ultrasound committees, and his main clinical interests going forward include comprehensive diagnostic and procedural ultrasound, sports coverage, and medical education. And he's going to be going ahead and giving us a presentation today on the anterior knee and patellar tendinopathy. All right, Derek, I'll go ahead and let you then share now.
All right, just want to confirm that you can see my slides and hear me.
Yep, that looks great.
Okay, perfect. So thanks, Dr. Shea, for the introduction, and thanks to everybody for joining this morning, along with those who may be watching afterwards online. As Dr. Shea said, I'm going to be presenting a case of patellar tendinopathy with an intra-tendinous cyst as part of the AMSSM Sports Ultrasound case series. I don't have any disclosures to report. And for our learning objectives, we're going to be reviewing the scanning protocol for the ultrasound evaluation of the anterior knee, along with identifying normal and pathologic ultrasound findings and composing a diagnostic report that are both going to be specific to this case. For our history, we have a 21-year-old male collegiate basketball player with chronic intermittent anterior knee pain that's occurred off and on really throughout his career. He has known proximal patellar tendinopathy based on prior preseason ultrasound screening examinations that were conducted on all athletes. He had recent worsening with an increasing preseason workload as they transitioned from the off-season into their preseason workouts. His prior treatments have consisted of activity modification, including intermittent rest, patellar tendon straps, a rehab program guided by his athletic trainers, and then general pain reduction modalities such as ice and NSAIDs as needed. On physical exam, he had no gross abnormalities, including no effusion. He was tenured to palpation pretty much throughout his patellar tendon, but most notably at the proximal and the mid portion of the tendon. His range of motion was full and intact, along with his strength, although he did have a little bit of reproduced anterior knee pain with resisted knee extension. His ligamentous exam was normal, and functionally, he did have some mild anterior knee pain with a single leg squat, along with jumping that reproduced his typical pain. In this case, we do have prior imaging from a few weeks before our evaluation. And this MRI was ordered for the exact same reason that we were doing our evaluation. It was to evaluate for anterior knee pain. On the left, you can see a T2 weighted axial MRI cut with the arrow denoting a point of pathology within the patellar tendon. As you can see here, this is very well circumscribed, and it's on the medial aspect of the tendon. We'll also scroll through on the right side just so we can kind of get a better understanding of just how much of the tendon is involved with this specific process. Switching to the sagittal view, we can again see just how much involved, or how much of the tendon is involved in this process as well. And we'll scroll through here from a lateral to a medial. The impression for this specific portion of the MRI was patellar tendinopathy with a mid-grade partial thickness interstitial delaminating tear within the patellar tendon. So at this point, you might be asking yourself, why are we doing an ultrasound evaluation if we already have the MRI and we have this information? Well, there were a couple reasons for this. one of our orthopedic surgeons, who's a team physician, reviewed the MRI and kind of had some additional questions about the report. First and foremost, the question was, is this an interstitial tear versus is it actually more a cystic structure? We also know that when evaluating patellar tendons, and specifically for the evaluation of patellar tendinopathy, that ultrasound is at least equivocal, if not superior, to MRI for further characterization of the patellar tendinopathy. So that was kind of reason number two. We expanded our anterior knee evaluation to include all anterior knee structures, just to evaluate for other contributors as well. So here is the anterior knee ultrasound scanning protocol, which has been reviewed in prior videos. We have our standard structures listed here, and I'm not going to go through them one by one, as we'll go through them throughout the entirety of the presentation. But a few additional structures to point out that can be reviewed based on your clinical question that are not reviewed in this presentation include the infrapatellar branches of the saphenous nerve, and then also you can consider doing a plica evaluation. For our knee exam, we used a high-frequency linear transducer, which would be appropriate in the vast majority of anterior knee exams. For the patient positioning, you'll have them in the supine position with some degree of knee flexion, anywhere from about 15 to 30 degrees for the vast majority of the exam. Now, notably in this position, the tendons aren't going to be under full tension. So in order to increase the amount of tension or tautness on the tendons and optimize your ultrasound imaging, you can do one of two things. You can either increase the knee flexion up to, let's say, 90 degrees or so, or you can leave the athlete in this position and have them do an isometric quad contraction. We're going to start with the midline structures of the anterior knee exam, going from proximal to distal, and we'll transition into the medial and lateral structures from proximal to distals to round out the entire anterior knee exam. We're starting with the quadriceps tendon and long axis as pictured here on the left side of the screen. You can see that this is a multilaminar fibular structure extending from right to left and inserting on the periosteum of the patella. The video on the right side of the screen is going to show the entirety of the insertion of the tendon onto the patella from a lateral to a medial scan. We don't see any focal hypoechogenicities, thickness, any defects, calcifications that would indicate enthesopathy. So we call this a normal quadriceps tendon in the long axis. For all tendons, we want to look at them both in short axis and long axis. That's what we're going to do here on this slide. Specifically in short axis, we can watch the transition of the quadriceps muscles into the tendon and then onto the insertion of the patella itself. So starting with the top left image, we can see all four quadriceps muscles labeled, with the rectus femoris being most prominent in this view and smack dab in the middle. On the top right, you can see the rectus femoris starting to become smaller as it forms into the quadriceps tendon first. And then you can see that transition further occur with the bottom left and then the bottom right, where we have mostly quadriceps tendon and then maybe some vastus lateralis present, but still a portion of the VMO present as well. In the video on the right, we'll watch this transition occur from a proximal to a distal scan, watching the tendon form and then watching the tendon also insert onto the patella itself. We don't see any abnormalities for this muscle to tendinous transition, nor any obvious concerning abnormalities on the insertion. Therefore, we call the quadriceps tendon normal. We'll flip back to a long axis or a sagittal view and evaluate the suprapatellar recess of the knee joint here. The suprapatellar recess is going to be the hypoechoic line that's deep to the quadriceps tendon and bisects the two fat pads that are just proximal to the patella. Those consist of the suprapatellar fat pad or the quad fat pad and the prefemoral fat pad. Here we can see a distinct line that represents a little bit of synovial fluid, which is physiologically normal. However, we don't see any large effusion. Therefore, our concern for an intra-articular process is lower. For the patella and the prepatellar bursa aspect of the scan, we're looking for a couple things. For the patella aspect, we're looking for any cortical irregularities that could indicate some sort of fracture that could be contributing to the anterior knee pain. We can also look for fluid collections within the subcutaneous tissues that would represent the potential space that is the prepatellar bursa. And for that evaluation, you do need to use very light transducer pressure. Otherwise, you're going to collapse those tissues and that fluid plane together, and you wouldn't see it regardless. However, in our case, we don't see any cortical irregularities or fluid collections within the subcutaneous tissue. Therefore, this is a normal patella and prepatellar bursa. The next few slides are going to be looking at the patellar tendon, starting with long axis and transitioning from proximal to distal, and then flipping to short axis. As I previously stated, we want to look in two planes. For the proximal patellar tendon, you can see here in the center image on the top, the arrow pointing to an area of hypoechogenicity and thickening, and likely also admittedly some anisotropy in this particular clip. Distally on this picture to the right of the picture, you can see some of that, a little bit of an anechoic defect that's going to be correlating to the area that the area of focus that we pointed out on the MRI previously. And we'll look at that further in the next couple slides. On the bottom left video, we'll scan from a medial to a lateral position, looking at the origin of the entirety of the patellar tendon. And at the beginning of the video is really where you see the majority of the thickening and the hypoechogenicity present. The middle video is going to focus more on this anechoic defect, which we'll look at in further detail on the next slide. But we can really see how proximal this extends and how we have fibers both above and below this cystic defect. On the right here, we're going to put color Doppler on in order to evaluate for neovascularization. And we do see several vessels present, indicating the presence of neovascularization. So far, we have a pretty obvious patellar tendinopathy process going on, along with we're going to further evaluate this anechoic defect. In the mid-patellar tendon, in the top image, we can now see that defect in its entirety. So we can see that there's an anechoic signal within the patellar tendon that appears to be elongated and somewhat tubular, with fibers both above and below. So we 100% agree that this is delaminating and it's separating those fibers. However, it's holding its shape under a little bit of transducer pressure, indicating that there's some sort of substance within this anechoic defect. We'll scan from the medial to the lateral position on the left video, evaluating and getting a better reference for what this actually looks like, along with its association with the remainder of the tendon, where we can still see some of the thickening and the hypoechogenicity, specifically at the distal aspect of this video. And then we'll also put color Doppler on here as well, again, identifying the presence of neovascularity. For the distal patellar tendon, this shows more of the same, with the arrow pointing to an area of thickening, hypoechogenicity, but also some new findings. A little bit of cortical irregularity at the insertion, along with some hyperechogenicity is just proximal to that, indicating some probable dystrophic calcification, kind of supporting that this is a chronic process and has been ongoing for a long period of time. On the bottom left video, we'll scan the entirety of the insertion and the footprint of the tendon onto the tibiotubercle, showing more of the same. And then we'll also put color Doppler on here. And again, we have neovascularity present at the distal aspect. So this was present throughout the entirety of the tendon. Lastly, for the patellar tendon, we'll flip to short axis and evaluate this kind of just in a different view. So in the top middle image, we can now see how well circumscribed or circumferential this defect is and how well contained it is. It's not extending into the surrounding tissues. Again, it's holding its shape under a little bit of transducer pressure, so it's not easily collapsible, but it does have some fluctuance to it. You can also see some of the mixed echogenicities in the patella tendon adjacent to it, which are those tendinopathic findings that we've looked at on the other slides. On the bottom left video, we'll scan from proximal to distal. And I first want you to focus on the anechoic defect and some of the septations that pop through, indicating and supporting that this is most likely a cystic structure. I also want you to look at the hypoechogenicities just to the right of the image or laterally, or the anechoic defect, as those are going to represent just how diffuse this tendinopathic process is. We're also going to be putting color Doppler on here to see where exactly these vessels are in relation to the anechoic defect or the cystic structure. That's the point of interest. And we can see here that they're adjacent to, but not necessarily directly associated with this anechoic defect. So they're not surrounding or going through that anechoic defect, but rather they're kind of where we expect them to be within this tendinopathic process. Obviously, I've used a lot of words to describe that, and we have to find a way to summarize that. So I'm going to wait and do that whenever we wrap up in the report. Next, we're going to circle back and evaluate just a couple structures that you can look at while you're looking at the patellar tendon. But for the purpose of the presentation, we'll look at these separately. So we're going to start with the superficial and the deep infrapatellar bursa. These are going to be potential spaces just superficial or just deep to the patella tendon itself, and they're going to be represented by the top and the bottom arrow respectively. In this case, we don't see any hypoechoic or anechoic fluid collections present. Therefore, these are normal. Hoffa's fat pad sits just deep to the patellar tendon as well. And here, theoretically, you might be able to see some anechoic or hypoechoic defects indicating that you could have maybe a tear in there. However, it's likely most useful to evaluate for vascularity in the presence of a Hoffa's fat pad inflammatory process such as impingement. Hoffa's fat pad in general is already vascular, so in order to do this and kind of support your clinical impression, you do need to compare to the contralateral side and kind of get an idea of how much vascularity is present on this person normally versus the affected side. In this case, his Hoffa's fat pad was completely normal. Next, we'll transition back proximally and look at the medial and the lateral structures, starting with the medial retinaculum, including the MPFL. You can see the medial retinaculum in the top image extending from the patella over to the femoral condyle. And again, this is a very well-defined structure, fibular structure that we can see pretty easily. On the bottom left image, we're going to see the transition from the VMO into the retinaculum. And then the MPFL is within this structure at some point, although it's difficult to decipher between the two necessarily. We don't see any defects on this particular scan from proximal to distal, but we'll also evaluate with a little bit of a medial to a lateral stress under dynamic ultrasound evaluation, looking for any gapping or defects within these fibers that could indicate patellar instability secondary to a medial retinaculum defect. In this case, we can see those fibers tensioning appropriately under a little bit of stress, and therefore the medial retinaculum is normal in this case. For the lateral retinaculum, this, as you can see on the bottom or the left image, is not quite as well defined as the medial retinaculum, and it's a bit underwhelming on ultrasound. We'll scan through on the right image, showing the entirety of the retinaculum, and we don't see any obvious defects. Therefore, we call this a normal lateral retinaculum as well. Next, we'll look at the anterior horns of the medial and the lateral meniscus. This kind of starts to get into the medial and the lateral knee scans. However, we wanted to kind of keep this at the anterior aspect and just look at the anterior horns. The medial is going to be on the left and the lateral is going to be on the right. And the menisci are represented by the asterisk or the hyperechoic triangular structure between the femur and the tibia. We don't see any hypoechoic defects within the menisci, representing that we likely don't have any peripheral tears. We also don't see any obvious hypoechoic or anechoic fluid collections adjacent to the menisci, representing a perimeniscal cyst or a cyst within the meniscocapsular ligament or something like that. Therefore, these are normal menisci. Lastly, we're going to be looking at the trochlear cartilage within the trochlear groove. So in order to do this appropriately, you can and should probably consider increasing the knee flexion up to about 90 degrees or so. And you can move through different ranges of motion with extension and flexion in order to evaluate a larger surface area of this structure. This is going to be represented by the asterisk again with the hypoechoic line just deep to the quadriceps tendon and just superficial to the cortical line that's the trochlear groove. We don't see any irregularities on the borders of the hyaline cartilage, therefore we call this normal as well. So for our final report, we have all our identifying information, including the logistical information, as well as the clinical indication that was anterior knee pain with a questionable patellar tendon interstitial tear versus an intra-tendinous cyst. We have a comparison with the left knee MRI, and then our transducer selection, which was the linear high-frequency transducer. I'm not going to go through all the normals that we called again. However, like I said, we spent about 4 slides looking at the patellar tendon because there was so much going on. So we have to find a way to summarize that. So this was our description here. A diffuse hypoechogenic thickening of the patellar tendon, most notable at the proximal and distal aspects, with a well-defined area of elongated, cylindrical anicogenicity at the medial aspect of the tendon. Neovascularization is noted throughout the tendon, but not directly associated with the anechoic defect itself. So our impression was a diffuse patellar tendinopathy or patellar tendinosis with an elongated cylindrical intra-tendinous cyst at the medial aspect of the tendon. A quick comparison slide here looking at the difference between interstitial tears versus intra-tendinous cysts. We have pictures from a publication by Jacobson on the left and then our case on the right. Jacobson and his group described partial thickness interstitial tears as focal, hypoechoic, or anechoic defects or clefts that are often irregular and surrounded by the tendinopathic changes that we've described throughout the presentation. This specific publication, obviously you can see it very easily, but they're often not quite as discrete as this. However, in our case, you can see how, again, we have this well-defined circumscribed elongated anechoic structure that again holds its shape. It doesn't extend into any surrounding tissues. Not to get into the treatment much at all, but we did end up aspirating this specific structure, and our aspirate was a very thick, gelatinous, kind of clear fluid that represented that of a ganglion cyst, again, confirming that this was a cyst. We were also able to see this delamination process that occurred, kind of a collapse on itself, so that we no longer had this sustained shape, but actually still had some hypoechogenicities that showed kind of where that delaminating defect occurred. So for the summary points of this presentation, ultrasound is a very highly sensitive and specific modality for patellar tendinopathy. And intra-tendinous cysts are actually quite rare, but very well-defined structures that you can see pretty easily with ultrasound. They may possibly be associated with some sort of pathology, such as a tendinopathic process, but they're so rare, we have such limited information on it that we don't actually know exactly why or how they form. A few acknowledgements and shout outs. Dr. Dan Cushman was first and foremost, he was my mentor on this presentation in this case, really my mentor throughout fellowship, and probably whether he likes it, I'm going to be picking his brain for years to come. A couple other people that deserve some acknowledgements are Dalton Brady, who's a PM&R resident here at the University of Utah, and Luca Tarlak, who's an undergraduate student that helped with this case as well. I thank everybody for listening, and I'll open it up to questions and comments at this time.
All right, thanks, Derek. That was great as expected. So yeah, just really appreciate once again that obviously I think you guys were going into the scan with a pretty, focal and localized question, but you guys still completed kind of a comprehensive, scan just to make sure you kind of were not missing, anything, and kind of adding all those puzzle pieces together to kind of come down to appropriate, diagnosis. So once again, kind of exactly, what we're looking for here. So a couple points just kind of make with this case. Like you said, I mean, these are, fairly atypical cases, but I think really important to be aware of, just because as you had mentioned, when you're thinking about a tear versus an intratendinous ganglion cyst, treatment can start to be, very, very different for these conditions. And so then going to be extremely helpful that ultrasound can kind of, add on to the other imaging modalities to kind of help to differentiate those diagnoses. I know in this case that you had additional imaging, other additional imaging, which I do think is important because, I have seen just, a couple of these cases previously, And one reason being is just to kind of overall evaluate that bone morphology as well too. Main thing to bring up is that, just because these ganglion cysts are fairly, atypical in the patellar tendon, usually that means that they're having, a lot of repetitive use or over trauma to that area. Sometimes that can just be through the actual sporting activity, but it really starts to also raise the question, is there some type of underlying bone morphology, such as trochlear dysplasia, that might be predisposing these athletes or these patients to develop such an advanced finding within the patellar tendon. So just as you guys had already done, usually getting some type of other imaging modality along with this, I think can be helpful to kind of evaluate for that bone morphology, just because sometimes that may need to be additionally addressed to hopefully prevent reoccurrence of these cysts. As you had mentioned, with the case, looking at these ganglion cysts, it's an atypical location, but we see ganglion cysts, in other areas all throughout the body. So just had like you guys had done, for this scan, is I think, when you do see these kind of atypical, masses and things like that, just going back to the basics, as you had mentioned, and the way that you're describing it. And one key feature, I think, for differentiating these cysts versus then a tendon tear, or a partial tendon tear, is going to be that compressibility. So we know that usually with these ganglion cysts, they're going to be non-compressible, and so adding that in with your ultrasound, which we're able to do that you cannot do with other imaging modalities, is one of those kind of key features. And then just the other things that you had said is that, usually these are going to be kind of well circumscribed, either circular oval masses, non-compressible. They're usually going to be hypo or anechoic, usually demonstrate no vascular flow on color Doppler. And then to some degree, they can have then posterior acoustic enhancement. So all the features that we're kind of seeing. So that was, really helpful to see all those aspects. And once again, even though this is an atypical, location for it, as long as you start to describe those features and knowing that it is possible to have this pathology at this area, can be something that you can start to identify. One other thing that Doug Hoffman wasn't able to kind of make it on the call today on the presentation, but he did want to also mention, that for the patellar tendon kind of lookalikes, that you can start to get some changes within the tendon occur with other, inflammatory arthritis conditions such as gout and hydroxyapatite deposition. So once again, just, something to be aware of, that calcifications can occur within the tendon at the patellar location, but also, development of these cysts, as well too. So also including that kind of in the differential diagnosis. So I think those are kind of some of the major points that I wanted to at least bring up, but I'll go ahead and open it up to any other comments or questions that anyone else might have.
Hey, it's Ryan. I just have a couple quick points. So first, Derek, like Steve said, as expected, great job with a fairly rare and unique diagnosis here. Like Steve was saying, we don't see these very often. I agree with all the points that you made and that Steve made as well. Two things just to mention. My protocol, I think, is fairly similar to what you presented, kind of spanning both anteromedial and a bit anterolateral. When I scan the anterior knee, the one structure that I will routinely scan and add into my protocol here, and I think you mentioned it in one of your first slides, is the infratellar branch of the saphenous nerve. It's a structure that can cause symptoms and can be pathologic in this region. So I'll add that in to all my anteromedial scans. And the other thing to mention, just from an anatomy perspective, so going back to your slide, looking at the deep and superficial infrapatellar bursae, typically those are going to sit pretty far distal at the distal aspect of the tendon. So we typically talk about the deep infrapatellar bursa between the distal most insertion of the patellar tendon and the superficial most aspect of the tibial tubercle. And then obviously the superficial infrapatellar bursa, same location, but just on top of or superficial to the tendon. So just wanted to make that point. But Otherwise, great case, great presentation, great ultrasound images, and really excellent job.
Thanks, Dr. Cruz.
All right. Well, I don't think I'm seeing any other questions or comments unless anyone else wants to chime in, and I don't see anything in the chat. So I think I'll go ahead and conclude the presentation today. So once again, thank you so much, Eric, for the presentation about this kind of atypical case and kind of going through a comprehensive exam, exactly what we're looking for. So really appreciate it. So we'll have again another case in 2 weeks. This is going to be going over an abdominal scan, taking a look at anterior cutaneous nerve entrapment syndrome. So we'll see everyone again in 2 weeks.